go live. Okay. Make sure we're up and running here. We'll get started. Welcome everyone to this discussion of FDMAS Beyond 40 with Dr. Edward Hsiao and Shelley Hebert. This is the 5th installment in FDMAS Community Connects, our monthly webinar series. I'm Tova Burstein, Community Engagement Director with the FDMAS Alliance, and I'm going to start us off with some quick housekeeping. We'll be recording today's session and sharing afterward on our website for access to anyone. We've collected questions ahead of time via our web registration form, but we'll also watch for questions in the Facebook chat. You can test out that feature by dropping a hello or your favorite emoji in the chat now to let us know that you're here. Or if you're having trouble seeing or hearing, you can show us there. Awesome. Welcome, everyone. We're happy to have you here. So at the closeout, we'd really appreciate it if you'd complete our 3-minute post survey, which will help us show our impact, continue to support webinars like these, and provide feedback for upcoming web programming. And finally, this program is made possible by our donors, with special thanks to Ionis, Ultragenyx, and to our Charlie's Angels monthly giving circle for their support of these educational programs. We're committed to keeping this material free, and you can help by making a donation on our website. With that, I am going to turn it over to our speakers for today. Dr. Edward Hsiao is a professor of endocrinology and metabolism at the University of California, San Francisco. He's the director of UCSF's Metabolic Bone Clinic and the director of UCSF's Diabetes, Endocrinology, and Metabolism Fellowship Training Program. His research focuses both on fibrous dysplasia McCune-Albright syndrome and fibrodysplasia ossificans progressiva. He's worked with the FDMAS community since 2004 and is an active member of our Medical Advisory Council. And our community member, Shelley Hebert, who's a longtime community member and mentor in this space. We're very grateful for her calling in today from Florida to share her experience. With that, I am going to turn it over to you to lead us through today's conversation.
All right. Thank you very much, Tova, and welcome everybody. I'm going to go ahead and share my screen. Okay. All right, so thank you everybody for joining us today. We're very excited to be here, and we're going to talk a little bit about fibrous dysplasia and McCune-Albright syndrome, specifically with relation to aging. And just at the beginning, as with all of my talks, I do have some disclosures. We do receive research funding, grant support from a number of different companies, as well as research foundations. These pose no conflicts of interest for this presentation. And also that the opinions that are presented here today are those of the respective speakers and not of the FDMAS Alliance. And also for me, it's very important that I acknowledge the people that have helped with all of our research in the laboratory here, as well as on the clinical side. This is a recent photograph from our team now that we're able to get together again, which is really nice. We won't be talking specifically about many of the research things that are going on, but it's really with this team that we've been able to identify a number of things that are going on, both clinically as well as in the basic science research arenas, and also our funding sources. So for today's talk, what we wanted to focus on was really the impact of aging on FDMAS. We'll start by meeting a patient, Shelley, and then we'll have a very brief discussion about some of the key items about aging and FDMAS. And then we'll open this up for questions. So there's just a couple of key things to keep in mind. For privacy and safety reasons, we can't address individual medical concerns of any one patient today. If you need medical assistance, please reach out to your physicians and your medical team for advice. This presentation may discuss off-label or investigational therapies. You should discuss with your doctor whether or not these are appropriate before starting any of these therapies. And as always, each patient is an individual, and you should discuss with your physician whether or not certain ideas might be appropriate for you and safe. So with that, let's go ahead and get started with a conversation with Shelley. So welcome, Shelley. Thanks very much for joining us. Let me stop the screen share so that we can all see you. All right. So first of all, Shelley, thanks for taking the time to join us today, especially to have this conversation. And what I thought we should do is have you start by telling everyone a little bit about you and how you were diagnosed with FDMAS.
So I was diagnosed when I was 4.5. I actually was riding a bike and fell and broke my femur. And that's when they diagnosed or saw the actual, I shouldn't say that's about when I was diagnosed. That's when they saw the problem. They actually thought it was cancer at first. And then after a new resident kind of got involved, he did the research, got in touch with an endocrinologist, and they, looking at all the symptoms with the cafe au lait spots and just what was going on, that, you know, it was McCune with the polyaesthetic fibrous dysplasia.
Okay, and we'll talk a little bit more about, you know, just sort of your diagnosis and some of the things that you've been living with. But can you tell everybody a little bit about what you're doing now?
I moved to Florida from Wisconsin. Did that pretty much for my health. It was a little time to get out of the cold and the ice and the snow and move to somewhere that was a little bit more adaptable for me and better for my body, which I think overall, once I get all my doctors switched over, that'll be a wonderful thing. That's been a challenge, I have to say. Didn't expect it to be such a challenge, but that's been a challenge. But I think we're on the road upwards now, so that's a good thing.
Great, great. Thanks very much for sharing a little bit about that. So let's step back for a moment and ask, so when you were growing up, what do you remember most about your FDMAS?
I remember we talked a little bit about the anxiety. Well, anxiety was a big issue that I had that was not dealt with at that time. I don't know if it was they just didn't have the medicine. They didn't know that it was part of the disease, but you know, one minute you'd be playing with your friends and the next minute you'd fall and break your legs and you'd be on your way to the emergency room, and then you'd be put into traction and you'd be in the hospital for months on end, or you'd be put into a body cast because you had to have surgery because, you know, you had to have your femurs had to be operated on and rods had to be placed in. So life was ever changing, and it would change at a moment's notice, and anxiety ran very high. So that I remember very well. And that is something as an adult, that is, you know, you still run that problem because your disease is something you live with every day. But now they have medicine to help with that. So to me, I take clonazepam, which helps me with my anxiety, which is a wonderful thing that I did not have years ago that helped me and has helped me a lot. So that's one of the things that I remember. And I just remember that, you know, you just didn't have a normal life, but my parents always forced me to try and have as normal life as possible. You know, when I wasn't in the hospital, they not forced me, but they pushed me to be as, and I don't know what word to use other than normal, but, you know, to do what other kids were doing and to live the life that they were living. And that didn't include being, I guess, as least handicapped as possible, I guess.
And I guess in those activities, that's a really important point of trying to do things, you know, to the most extent that you can.
Yes.
When you were trying to do these activities that other kids were doing or other people were doing, you know, was that something that was sometimes uncomfortable? Was that something that sort of pushed your, you know, challenged you?
Well, yes, it did, because you had to find ways, but you just did it a little different. And I have pictures of where I was in the paper, you know, bowling in my wheelchair. You know, I went with groups I was involved with. You just did it a little bit different. You did it in your wheelchair, you know. So even though you were a little different, you just found a way to make it work. It's just that before the ADA, it was very difficult, and it still is very difficult. And that's one of the things I'm finding in Florida. ADA is very difficult down here, which I find fascinating, the lack of ADA, where when I was young, there was a lack of ADA. And, you know, from kind of like 85, when that started, going forward, things started to change. Even in my high school, my parents were very, they were the ones that were, I don't know what the right word is. They went to the school district. They were the one who got the school district to put the lift into the high school so I could go to a regular high school. So if I had surgery, I could use a wheelchair to go, you know, up and down the floor so I could go to a regular high school. So I was as normal as possible. You know, I was amongst my friends, you know.
Yeah, so having an advocate, I think, is
Yes.
really, you know, to be able to is really important.
Especially,
and I think, go ahead.
Yeah. You, especially when you're young, your parents, you know, they need to be your advocates, you know. And I don't know, my parents advocated more that I be less different and more alike than to separate myself out. You know, that was, and I think that was a positive thing, even though I did need a lift to get upstairs, but so did other kids who broke their legs or, you know, had challenges, got, you know, hurt on the football field and now needed to be in a wheelchair. You know, they had challenges too, you know. So, so that's kind of how they raised me, and they were my advocates to just, you go on with life and you do it the way everybody else does.
Yeah, this is great, because I think this is, you know, certainly your description of trying to do activities and be as normal as possible sounds like something that's really have stuck with you.
Yes, yes, yes.
So that's great to, I think, to think about this context of what you, how you grew up and what was going on at that time. So over the past 10 years, tell me a little bit about what issues really have been most prominent for you. So you mentioned anxiety. Are there other things that you are concerned about?
Well, over the 10 years, things are changing. So, you know, before I had youth on my side, and with all the surgeries and everything like that, you had youth on your side. Now I don't have youth on my side. I have age on my side. And with aging comes negativity, I guess, with bones that, we weren't faced with being young. So like right now I'm dealing with, what am I going to do to help myself to continue to withstand the pain levels? And one of the things that I've been just right now dealing with my neurologist and my neurosurgeon is looking at medical marijuana as one of the options, as opposed to continually getting epidural injections for my upper C-spine, injections into my chest area for my rib cage. Your body can only handle that so long, and that's rough to go through. Those are not easy procedures, RFAs and, for long-term periods of time. So that's where we're kind of stuck right now with, is the long-term management of the pain and how, if the bones are gonna kind of collapse, like the rib cage, and how is that going to be managed over time? That's kind of where we're stuck, and how we manage that.
And so pain sounds like it's a big or a central issue for you.
It is.
How have you managed the pain?
So through my whole life, holistically, with massaging and massage therapy, swimming is a huge part. I mean, I would say that everybody who has McCune should swim, because there's no pressure on your body. And from the inflammation to just everything, it's so good for your body. And out here, that's one of the key things, is to be able to do that out here, all year round, and have it accessible and easy. So but otherwise managing it, with opiates or with, like hydrocodone or ibuprofen, or just the basic Tylenol, the basic drugs that are out there, acupuncture. I'll do anything. I'll try anything. That's how I've managed it, to see what will work and to see how long it will work. And but I'm kind of gotten to the point where we're pushing that envelope, and we need to start looking at different avenues.
Okay. And have you had any changes in your teeth or jaw pain or any sort of craniofacial fibrous dysplasia types of symptoms?
I did. One example is in the front of my mouth. They did a bone sample, a bone, I can't think of what it's called. Biopsy, thank you. Yep. Right under, I don't know if you can see here, and when it grew back, NIH did it to get a sample of my bone, and it grew back, so it distorted my teeth, and now I have growth going on here, and I have changes going on in my skull, and it's going on around my optic nerve and around my ear, around my ears, the canals. I actually, about 8 years ago, right before my father passed away, had surgery to open up my ear canal because it had closed from the fibrous dysplasia, so I could hear again, which I was very blessed. It happened. They caught it right away. They opened it right away, and I can hear, out of it. So I do have a lot of that, and they're worried about the growth that's going on around my brain right now. So they're looking at that right now.
Okay. What do you think has been beneficial for managing your FDMAS? If there's a piece of advice that you can give to the other patients who have FDMAS?
Well, if I could give a piece of advice, if I could go back to, well, not to when I was young, because when I was young, they didn't have the things that they have now.
Mhm.
But the technology that they have now, like they have lifts for your cars, they have scooters, they have things that they didn't have available. You know, they had just manual wheelchairs when I was young. Um, you know, I wouldn't overuse my joints. I wouldn't. I've had, you know, multiple surgeries of my rotator cuffs, carpal tunnel surgery of my wrists. You know, I did want to be independent. You know, that is how I was raised, to be independent. And there's a lot to being independent, but there's also a lot to thinking about, well, hey, you know, 40 years down the road, I'm going to need those joints. So I need to be independent, but I need to care for those things.
Mhm.
So how you go about doing that over the next 40, 50 years of your life, I think is very important to do. And I mean, that's what I would go back and change. Um, you know, yeah.
It sounds like sort of the balance of life and disease is, I think, what
Yes.
you had mentioned.
Oh, exactly. Exactly.
Okay. All right.
Mhm.
Great. Anything else that you'd like to tell everybody? And then we can.
No, I think that's pretty much it.
All right. Well, thank you very much, Shelley, for taking a few minutes to tell us a little bit about your story. I think what we'll do is we'll talk a little bit more about McCune-Albright and fibrous dysplasia with aging. And this will be building a little bit on what Shelley was telling us a little bit about so that we can focus our discussion. And then we'll bring Shelley back later on during the question and answer period so that we can discuss any questions that you might have. So let me restart this. Okay. So as Shelley was describing, one of the important things about FDMAS, and which I think many people already on this webinar already know about, is that McCune-Albright syndrome affects many different organ systems. And this is important to keep in mind because these are exactly the organ systems that we need to think about as patients get older. So these include cafe au lait skin lesions, the fibrous dysplasia of the bone, various endocrinopathies, including affecting the pituitary with growth hormone hypersecretion, the early puberty, which may have impact later on, as well as thyroid hyperactivity and Cushing's syndrome. There's also some data showing gastrointestinal growth, and that some patients with FDMAS can have actually tooth fragility and increased numbers of cavities. Oops. So as you're aware, we typically concentrate on many of these aspects that occur early in life. And many of them are definitively managed early on. So things like in McCune-Albright syndrome, you might end up with growth hormone hypersecretion. There's often pituitary hyperfunction, and these may be treated medically if needed. But one of the things about the growth hormone hypersecretion that we've seen is that sometimes they're relatively silent and may not be easily identified earlier on in life and may actually present a little bit later on in patients who are maybe in their 20s or 30s. And this becomes a factor that we do need to follow and watch for. Also, hyperthyroidism may require different types of interventions, potentially surgical removal, and then also a thyroid hormone replacement after the surgical removal. And so making sure that these are tuned correctly are really important. And then also likewise, if there are adrenal tumors with Cushing's syndrome that were presenting early on, there may be surgeries that may be required, which may require some sort of lifelong steroid replacement. And so making sure that those are all addressed are really important. Finally, there's always the fibrous dysplasia of the bone. And as Shelley had described, this may involve a lot of pain management and potentially orthopedic interventions and also treatments for fractures and deformities. And so these interventions can start relatively early on in life and can continue. For the purposes of today's talk, I think we're going to focus on a couple of different things. There are many other aspects that are also individualized because each person's McCune-Albright's or fibrous dysplasia is a little bit different. And so there are going to be small, not necessarily small, sorry, but individual different organ systems that may be affected. And so, your physician will help you with those. But I'm just going to highlight some of the key things that we're going to talk about. So we'll talk a little bit about bone health and managing fibrous dysplasia related bone pain. We'll talk a little bit about, patients with McCune-Albright syndrome will still get the same conditions that everybody else gets in terms of as we all get older. And so we'll talk a little bit about that, and then also a little bit of cancer screening. And one thing that Shelley kind of alluded to, but we didn't really go into a lot of detail on, was really making sure that you assemble a medical care team to help you with these medical concerns as they arise. So we'll start with bone health and fibrous dysplasia. So fibrous dysplasia lesions are interesting because they tend to stabilize usually by the second or third decade of life. And if after that period of time you see significant growth of a fibrous dysplasia lesion, that should prompt evaluation for things like growth hormone hypersecretion or potentially development of a bone tumor or some other type of complication. This is particularly important, especially if there's craniofacial fibrous dysplasia, because it can actually affect things like the vision. So this is a person's eyeballs over here, as well as hearing. And so those types of assessments are really important. Fractures can continue to occur as the fibrous dysplasia bone is weaker than normal. And so that can still occur later on. And patients are still susceptible to other common conditions. So osteoporosis, as you get older or someone enters postmenopausal status, that is always a risk. And then arthritis, as Shelley had alluded to, sometimes if you have these different deformities or different biomechanics, you may be at accelerated risk of developing arthritis. And so that needs to be sort of watched for. And then, as I had mentioned earlier, the hearing and vision screening is really important, as well as dental health, making sure that your teeth remain healthy, especially if there are signs of tooth fragility, but also just keeping in mind that prevention is really critical because in some cases, the fibrous dysplastic lesions, if they affect the jaw bones, integration with implants can be affected. So as Shelley exemplified, bone and skeletal pain is actually a major problem for patients with fibrous dysplasia. And pain can get worse if the fibrous dysplasia lesion irritates the nerve. So this is just an example, one of my patients, where he has a fibrous dysplasia lesion, which is relatively stable on his rib, and actually affects both ribs. But the ribs are actually very close to each other. And so depending on which position he turns into, or if he's reaching for something, the two ribs can actually rub against each other and cause pain at that site. Having a pain specialist can be really helpful, and working with like physical therapy, occupational therapy, and prosthetics, especially if there are biomechanical changes, can be valuable for trying to prevent those types of episodes, without a lot of the different types of medications. New fractures can occur, and so having orthopedics evaluation and treatment are critical. Treatment with bisphosphonates or other bone medications can be a valuable part of trying to manage bone pain. And if any patients happen to have things like hip replacements or different types of prosthetics, you just have to keep in mind is that those prosthetics do wear out. And so normal wear and tear on a prosthetic can cause discomfort and also contribute to some of the pain and may require surgical replacement. As we'd mentioned, change in biomechanics, especially just because of different postures and different changes in the anatomy. But one of the intriguing things is that many of our patients here at UCSF have told us that hydrotherapy, physical therapy, these can be extremely valuable and helpful for patients. And I think Shelley's example is kind of exactly that, is that being able to be in a swimming pool, especially a slightly warmer swimming pool, can make people relax the muscles, but is also non-weight bearing, which actually can decrease a lot of the pain during movement. So in the questions that we had received prior to this talk, there was actually a number of questions that came up about FDMAS in women. And I will point out that in December, there's actually a webinar through the FDMAS Alliance that will be coming up on fertility and the FDMAS patient. This will be led by Dr. Gomez-Lobo from the NIH. I'm going to just touch upon this really briefly, is that women with MAS are known to have some challenges with some gynecologic challenges. And these include things like irregular periods and abnormal uterine bleeding, infertility, ovarian cysts, and sometimes primary ovarian insufficiency. I should note that spontaneous pregnancy is possible. So we do have patients with FDMAS who are able to have a child and carry the child without any problems. But this is something that is really important to discuss with the doctor, especially if the fibrous dysplasia might involve the pelvis. Interestingly, there are a wide spectrum of reports in terms of what happens to the fibrous dysplasia pain during pregnancy and with aging. And basically, it covers the entire spectrum. Some patients feel that they get better. Some patients feel like it's worse. Some patients feel that there's no change. So this is very much an individual response. And there's really no clear changes in bone or pregnancy outcome in women with FDMAS. So I think that's important to keep in mind. I also wanted to touch base really quickly about cancer screening. So we know that mutations in the GNAS gene, the gene that causes fibrous dysplasia and McCune-Albright, can be found in other types of cancer. These include the thyroid, the pancreas, and breast, among others. And the gene itself is actually important for controlling cell replication rates. There's data, which I highlighted here is this paper by Dr. Hagelstein-Rotman, that recently came out, showing that patients with FDMAS may have a slightly higher risk of thyroid, cervical, breast, prostate, and melanoma cancers. And there is always this potential risk of malignant transformation of the fibrous dysplasia lesions themselves into an osteosarcoma or a chondrosarcoma. And so because of this, age-appropriate screening should be done. It should be done on time and should not be skipped. Because the increase appears to be relatively small and it's difficult to tell just because FDMAS is such a rare condition, we're generally just recommending that age-appropriate cancer screening be done rather than actually more advanced or earlier screening. Unless there are other factors such as family history or other risks or exposures that may change your risks from that standpoint. So the other thing is that there are general conditions that occur as we all get older. And a key one for patients with FDMAS is osteoporosis. So the usual screening with DEXA scans, if this is possible, this can be difficult, especially depending on how widespread the fibrous dysplasia is and what bones that are affected. But there are other strategies for measuring bone densities if needed. You may need to be followed in a specialty clinic for your bone health. And things like falls and fracture prevention are actually really critical. To the extent possible, and that can be safely done, things like weight-bearing exercises, calcium and vitamin D supplementation, those types of things should be carried out. That's important for everybody with potential osteoporosis, not just patients with FDMAS. Pain management is also a challenge. So having a clinical pain management team or a service to assist with different options, I think is really important. As Shelley, as an example, we want to use judiciously opioids because this is a real disease with real consequences and real pain. So we need to consider the use of opiates in these situations, but making sure that other alternatives such as topicals are addressed when possible, the use of alternative therapies or complementary therapies such as acupuncture and acupressure, making sure that you have a good clinical pain management team is really important. And the one aspect, as Shelley had mentioned, was anxiety, but with any patient with chronic health conditions, we're very worried about mental health. And so making sure that you have somebody that can help address mental health aspects, including things like depression and anxiety, is really also very important. And a lot of this can change sometimes rather quickly as we think about changes in mobility, as well as obviously the chronic illnesses that might be present. So a couple of other things. We like to encourage patients to develop a comprehensive care team. This should involve your primary care physician. It may involve a metabolic bone specialist. This might be an endocrinologist or a rheumatologist, depending on where you live and who the specialties might be. Orthopedic surgery, mental health specialist, nephrologist, pain management. Pain management can sometimes be through anesthesia services or sometimes through neurology. That sort of depends. One thing that I didn't put on here is that for patients who suffer from headaches, there are often headache clinics that can help specialize in the management of headaches and the prevention of headaches. And those are often through neurology. And then one thing to consider, and this may not be for everyone, is a palliative care team. This is different from hospice, where hospice is that a patient is anticipated to die within a short time frame and sort of management of those particular issues. But palliative care is really meant to see what we could do to really help with pain management and with other management issues in health, and in a way that is really, I think, very respectful of the patients and the patient's wishes. So making sure that type of team is available, if that's something that you would want, discussing this with your primary care physician, it can be extremely valuable as you plan for the future. And I think for everyone, again, this is not limited to just patients with FDMAS. I know this is a very sometimes uncomfortable topic, but it is important to discuss advanced planning and estate planning with your family, physicians, tax advisors, and estate planners, because I think this is just something that we should all be doing in general, regardless. So I'm just going to finish up really quickly here. So there are just a couple of key considerations that I think I would try to emphasize. Each patient has individual needs, and depending on what organs are involved, you may or may not have other members to your care team. Your physician can help guide a lot of the different management aspects to help. And so putting together that team is really quite important. Make sure that you do your regular cancer screening on time. One other aspect that is really important is make sure you share the treatment guidelines for FDMAS with your doctors. And the easiest way to do this is probably to share the FDMAS Alliance website. There is a link there, and the paper that has is sort of the central paper is open access and available to everyone, and it's through the Orphanet Journal of Rare Diseases. It's basically a consensus statement from an international consortium for the management of FDMAS. And again, just over here, the FDMAS Alliance is really a critical resource and one I think that should be shared because this is both provides patient support, patient level support, but also is a critical resource for any medical providers who may not have as much experience with fibrous dysplasia or McCune-Albright syndrome. And so this provides a lot of connections. And there's also, I would point out, a provider directory in there. We do get questions, in terms of trying to find physicians who have expertise or experience in taking care of FDMAS patients. And so the provider directory is actually a great resource. It is also a great resource for your local provider or primary care physician if they have questions, that they can reach out for advice and other types of recommendations. And so with that, I will stop now and we can take some questions. Again, thank you very much. Thank you to Shelley for sharing and to Tova for the invitation to talk a little bit about this and sort of start the discussion. We are really happy to have the Metabolic Bone Clinic here at UCSF, where we do help take care of patients with fibrous dysplasia and McCune-Albright syndrome. And this is my contact information if you have any questions that come up. All right. So
Thanks.
with that, let me open up to any questions that may have come in.
Ed. Yeah, I did. I want to just say that I did drop in our chat box. I did drop the link to the treatment guidelines for folks to reference. You know, you can find that there. If there's other helpful links, I will put that in the chat as well. Thank you, Ed, for covering so much in such a short period of time, and to Shelley for hitting so many of that just by sharing your story. One thing I want to come back to, because we did have lots of questions about it, would be perimenopause and menopause. Are there changes that we know happen, or something in particular that we should be aware of during that phase?
Yeah, it looks like Shelley, did you want to say something? Or?
I didn't know if you could see me. Yes, that is one thing we didn't touch on, because that is one thing that I am going through is perimenopause or menopause. And, you know, I wonder how that has affected me, and has that accelerated things for me. And then just after that, there is one thing I want to say about the dental. So if at some point we could come back to that, or if there's a question that I feel it's really important to say. So, yeah.
Absolutely.
Okay. Yeah, no, so I think this is a great question. So as far as we know, I think perimenopause and sort of menopause, there really aren't very many differences in FDMAS as compared to non-FDMAS patients, just in terms of like the onset and sort of the changes. In other words, it still occurs, you know, somewhere between 45 and 55 typically, you know, similar symptoms, you still get hot flashes and things like that. I think the challenges are that in perimenopause and certainly into menopause, what you see are things like, you know, in women just in general, you see an increased risk of osteoporosis, you see bone loss that changes, the usual changes in terms of depression and not necessarily feeling as well, or lower energy. And those same symptoms actually occur in patients with FDMAS, and in some cases might be a little bit more pronounced. So, you know, you have to remember that these are patients who are probably having episodes of anxiety and sort of, you know, not feeling well, having dealt with a lifelong situation of a chronic disease, and then all of a sudden you start ending up with sort of menopausal changes in terms of mental health. And so those can be sometimes very challenging. So making sure that you have a mental health provider or a primary care provider that can help support that, you know, help with the transitions, I think are really important. And then, as I had mentioned before, screening for osteoporosis. I think making sure that there is some way to ensure that you have, you're not suffering from additional bone loss, especially since sometimes bone density scans, you know, of the hip or of the spine, sort of the traditional sites, may not be so easy to do in a patient with McCune-Albright's or fibrous dysplasia. You know, you may have to go through to things like forearm scans or ankle scans, you know, things like that as an alternative. So making sure that those typical sort of symptoms and events that occur around menopause are also managed in patients with FDMAS are really important.
And you know, just because I know that I would be curious if somebody's watching and they actually have a younger child who had precocious puberty, had menses really, really young, and now they're managing that, that still goes the same. It's not like they should be concerned about.
So that is an excellent point, and that is actually going to be something that needs to be probably directly addressed with the patient's or the child's physician. Okay. Because one of the things that can happen is with the precocious puberty, there can be changes in the bone maturation timeline. And so what we do worry, thankfully with our current medications, many of those things can be managed. Mm-hmm. But what we do theoretically worry about is that there are changes such that a child, for example, a girl with precocious puberty, may not reach peak bone mass, and so would be at higher risk of osteoporosis as she gets older. But those are very individualized questions. A lot of it depends on timing of diagnosis, the severity, you know, what the interventions were, things like that. But I would encourage that to be a part of the discussion with the medical.
And then many of our questions talked about, you know, type 2 diabetes or cancer, you know, how is this related to FDMAS? And am I understanding correctly from your presentation that because the GNAS, the mutation is connected to some of these, it sounds like it's hard to know whether these other conditions are connected, and the care and treatment shouldn't change because of FDMAS. Is that?
Yeah. So let's start with diabetes. As far as we know, there is probably not a clear link between FDMAS and diabetes. Now, there are a couple of different factors that are related to that. At least on a genetic level, it's probably that there isn't a clear connection. At least the diabetes is so common that it's a little bit difficult to tease that out and sort of figure out whether or not there is a connection. And there are molecular data using like mouse models and things like that that suggest that the GS pathway is important for controlling glucose metabolism and pancreas function. However, the management of diabetes in the patient with FDMAS is not different. So, that wouldn't change anything. We still do recommend things like some weight loss, and we do still recommend the same sort of dietary monitoring, just to make sure that things remain okay. So.
And
then I guess the second question was cancer.
Yes.
So in the recent paper that came out in March, it does seem that patients with FDMAS are at slightly higher risk of cancer. So making sure that there are, but specific cancers. And so making sure that those screening tests are done on a regular basis are really important to do. So.
Perfect. And then, so another question we had was, how frequently should I have screening done for my endocrine panel, but also imaging of my bones?
Yeah, so that's a very individualized question. I think a lot of it will depend on how large the lesions were or what types of endocrine issues were present and when they sort of started to present. So that would be something that I would discuss directly with the medical team, just to make sure that you have the appropriate screening frequency.
And then we had a question, how do I go about finding a palliative care team?
That's a great question. And unfortunately, adult palliative care is very different from pediatric palliative care. And trying to find adult palliative care services, as well as actually putting together your team, can sometimes be challenging. What we have found that a good way to do is to actually start with your primary care physician and talk with your primary care physician about what your goals are in terms of what you would like, in terms of how aggressive the management should be and what your long-term goals are. Is it maintenance of mobility? Is it maintenance of other types of health? Those types of things. And oftentimes the primary care physicians have the best connections with things like the palliative care services. If you're interested specifically in palliative care, then looking around and talking to some of the larger hospitals can sometimes get you connections. There are some of the hospitals that we know are very fortunate to have things like a palliative care service or an in-home health service or those different types of services. But that's definitely not uniform. That's not consistent across the country. And so you do have to, it does take, unfortunately, sometimes a fair amount of effort. And I see Shelley sort of nodding about this, to really track those types of resources down. So Shelley, maybe if you can comment, what has been your experience and what works for you in terms of trying to find these different types of resources?
It's a challenge. So even I had a very long talk with my neurosurgeon, and he expressed, he's with, one of the biggest hospitals in Florida, and just the palliative care, or it just medical marijuana, which would have to be under palliative care as well, he has a difficult time trying to get his patients any type of care in that realm. If you have cancer, if you're in the oncology department, it's a different, game. Things are made easier, but it's very, very, very difficult. I have not met with a palliative care team yet. I have not been lucky to do that. If I do, basically it's kind of separate. They don't want to be associated with the hospitals. They want it to be pay by out of pocket. They don't want it to go through insurances here. So I haven't completely finished going down the avenues that I've been offered. So I don't have an answer for that, but it's very difficult, very difficult.
Yeah, actually, Shelley, you raised a really important point, is sort of insurance coverage. And that is extremely variable, especially in things like palliative care and end of life sort of discussions. We're not talking about end of life at this point, but those types of things, you can sometimes talk with a case manager over at your insurance company, and they can sometimes give you a little bit of insight into what options might be available. But certainly knowing what is inside your insurance plan is actually going to be really critical for thinking about those options.
Okay, thank you for that.
I know we've already gone over this, but I see more questions about this popping up, so I want to go back. Should somebody with FDMAS have more regular or earlier checkups for screening, like breast cancer screening, other types of screening, than the general population?
That's a great question. So I think that, well, the ideal for everybody should be that you should be having a yearly physical exam with your physician. I know that the reality is that most of us don't actually make it every year, but really making sure that there is a clear connection, I think, is really valuable for lots of reasons. I think, your primary care physician is your main entry point in for things like disability paperwork, things like, just sort of those, general assessments, even sort of depending again on your insurance, it may involve, trying to get connected with mental health resources and palliative care and sort of these other sort of resources. So making sure that you have regular contact with your physician, I think, is important. I think that, as of right now, I think that the right recommendations are that you make your, you do your cancer screening on time and, age appropriate at this point. The only things that sort of change, well, the factors that would change the frequency of things like cancer screening are going to be things that you should be discussing with your physician. So those are going to be things like, a known suspicious, let's say, breast mass, or a known family history of cancer, things that would normally increase the frequency or or require earlier screening. And so the screening, again, doesn't differ from what we would normally do, but may differ depending on each individual patient's sort of circumstances. And so I think that is the sort of the important thing to keep in mind.
It sounds like, something that we keep on coming back to, not just in this discussion, but in so many of these webinars, is communication with your primary care doctor. And, I want to reiterate that it doesn't have to be somebody at a big clinical center, as long as it's somebody who is going to listen to you and work with you. And certainly when we've asked our medical advisory council, which Dr. Hsiao, I know you're part of this body of advisors, that the treatment guidelines are really something they say this is an easy way to get word out and make sure that a general practitioner who isn't on our medical advisory council has the best guidelines at hand. Any other advice for really making sure, since that is really an important key player in making sure you get great care, any advice about finding a good general practitioner who's going to be knowledgeable?
Yeah, so I see Shelley has some is raising her hand. So let me give Shelley a chance to talk here really quick, and then we'll definitely talk a little bit about the finding a provider.
So specifically on this, I was very blessed to find a gynecologist who was very versed in MAS and had several patients with MAS. And so she was from, a younger age, was, able to be aware, to look, to screen. I think that was very important. I think that was more important than just having a general, doctor. I mean, my general physician was a good physician for me as well. But, I would say having a general physician, having a gynecologist that's familiar or willing to get familiar with McCune-Albright's, an endocrinologist, your pain team, and your, most importantly, I guess, is your orthopedic gynecologist. Those were my 5 go-to doctors, and they all worked together to take care of me. Those were in Wisconsin. And I was very blessed to have them young. And then when I grew up, I had them, and I found a different team that all worked together in my adult years. And I think that was very key in them handling that, like knowing when to screen me if something looked suspicious or came up, or like a cyst in my ovaries, and it was growing, and maybe they pushed me into menopause early to see if it would shrink, instead of doing a surgery that might not be needed. And they just willing, I guess, to go that extra mile. Finding that kind of a doctor is very important, I think.
Thanks, Shelley. I think, just to build upon that, finding and building your provider team really is about communication. So making sure that there's somebody that understands what it means to have a patient who's a little bit more complicated and may have other issues that require communication with other teams, I think is really valuable. Oftentimes, these are physicians that may be referred by word of mouth. If you have a friend who says that, oh, they really like their primary care physician, you should talk with them and see whether or not that might be a good fit. But really finding somebody who's a good fit, that is willing to, as Tova had mentioned, is willing to look at the guidelines and to say, okay, well, these are the things that we need to consider. And then also is able to help get you connected with people who can help complement your team, potentially mental health, chronic pain services, orthopedics, endocrinology, rheumatology, neurology. Those types of connections are really important. So
we are coming to the end here, but there are at least 2 questions that I really want to make sure to get to. The first is there any evidence that this FDMAS is flare-based, that there's triggers like infection or concerns about, like, well, do I operate, or is putting hardware and actually going to create a flare-up and cause more issues down the line?
Yeah, not that we know of. So we don't think that there's sort of like these episodic changes. But there's also a lot that we don't know. Even though we know the mutation and we know what that mutation does in many of the tissues, there's still a lot of things for us to learn about. So we'll keep people posted as we learn more about that.
Yeah. And then we have that note that for everyone, advanced care planning and end of life conversations are really important, but somebody has asked, is FDMAS fatal in any particular area or aspect of it a concern that way?
Yeah, no, that's a great question. We don't think that there is a significant change in terms of like lifespan. But I think a lot of it is that, you know, with patients, especially if they have severe FD that affects lots of different bones, that there is always a risk of things like fracture and complications related to the fracture. So, you know, the fracture may not be the ultimate cause of death, but it might be a fracture that leads to problems with, like, you know, the surgery and the complications. So, you know, we don't like to think about that, and we hope that that doesn't happen to anybody, but it is important to sort of think ahead and say, okay, well, you know, you might be at slightly higher risk. You know, there might be other sort of confounders. You know, just being able to be prepared, and at least, you know, letting your loved ones know what your wishes are, and how things could be directed is going to be extremely valuable, to make sure that people do what you want people to do, I think, in those situations. I would just add one really quick question. I think Shelley wanted to mention a little bit about dental stuff.
Yes.
Maybe we can end on that.
I did. And the one thing I didn't say is I spent as much time in the dentist as I did in all the other doctors, getting dental work done, which was key to my teeth now, because I do have good teeth, and they comment on that all the time. And when I was in Wisconsin, I ended up going to the dental school. And they took great interest in that, which was a good thing, because they put me with the advanced dentists that had graduated and were learning. And the school had something to learn and to get out of it, was the knowledge of working on me. But I got the benefit of having the newest technology, you know, them working on me, and it didn't cost anything for me to go there. So just FYI for other patients, that was something that came later in life to me, but it was a very good thing. And so I just wanted to share, you know, how important that is to keep your teeth, you know, as good as possible, you know, and that if you have a university or school near you, that might be an avenue, because teeth are very important. And I know that one of our advocates is working very hard. She has McCune, and she's trying to get the SMILE bill passed, and to get it where that's covered under insurance, which I think it should be, because it is a bone. And we all, I think, have problems with our teeth. But right now, I know it's not covered with, you know, insurance. So that's the only other thing I wanted to share.
Great, thank you. Yeah, you know, those are really important points, especially, you know, we always try to make sure that people do preventive maintenance on their teeth, because your natural teeth are much better than any sort of implants or things like that. So. All right.
Absolutely. Anything else that either you know, Ed, do you want to add anything else before we close out here, or Shelley?
No.
I would just say thank you, because I think these are important topics. You know, many of these things, you know, change over time, and so, you know, we look forward to assisting everybody, you know, both from the clinical side and from the research side. And so we really appreciate the interest. So, thank you.
Yes,
thank you.
Absolutely. Thank you both so much. You know, I think this is the beginning of a conversation, and we do hope that folks here, if you feel like your question wasn't answered, please do reach out to us. You know, at the Alliance, also our Medical Advisory Council really is very responsive to us or to your clinician. So please do reach out to us. We are so grateful to you, Dr. Hsiao, and for your insight and your service to this community. To Shelley for sharing so openly and honestly with us today. Thanks, of course, to our donors who made this possible, including Ionis and Ultragenyx, as well as our Charlie's Angels Giving Circle. I am going to post the feedback survey, which really does help us tremendously when we hear from you, in the chat. And we'd be so grateful to you if you'd fill that out. And with that, we'll hope that you'll stay tuned for information on our next webinar, which is going to be FDMAS and fertility, as Dr. Hsiao mentioned, and that will be on December 16th. So we hope we'll see you all then. Thank you, everyone.
Thank you very much.
Thank you. Are we done?
All right, hold on here.